The goal of this is just to lay a little bit of the working discussion for the things that we'll be talking about. Again, this is interactive, so please type things into the chat or unmute yourself and speak up. And these slides, again, are really just for framing purposes. So the first thing that we want to talk about, and we had some discussion about this on Sunday, is just the structural changes of methamphetamines. And so the key here is where you see the red, that's volume loss. And some of the key areas you'll see are down here at the bottom, there's a lot of red, that's the hippocampus. Hippocampus is really important for memory. And when you compare on the left side of your screen, which is the methamphetamine addicted individual versus the Alzheimer's patient, you can see a lot of that memory loss or the volume loss resulting in memory loss. Why is that important? Well, one of the hallmarks of Alzheimer's is memory loss. And look at the volume contraction that's happening in the individual with methamphetamine addiction. And that's really, really important. And that's something that we want our patients to understand. As we'll talk about, one of the hallmarks of a substance use disorder is that people don't think that there are really consequences. They'll give lip service to that, but in many ways, they're behaving as though there are no consequences. Helping people, especially people in denial or pre-contemplative, by showing them this kind of information can be very helpful in opening their eyes to the reality of their situation. Here's some additional PET scans. The top one here is a normal control. The individual below is someone who's been using methamphetamines. You can see the clear change in the red that's in normal, that's reduced and or absent in the methamphetamine user. That loss of dopamine transporters is really important. It results in a reduction in motor task ability and memory tasks. So you can see in the bottom graph the loss of dopamine and how it causes memory impairment. And this is obviously really important because memory is critical, for both adherence to antiretroviral therapy. If you don't remember to take your pills, you can't take them. And then it's also really important for sobriety. One of the big things that we teach in sobriety is really about new ways to cope with stressors. Stress is the greatest thing that causes relapse. And there are many kinds of stressors. But if you can't remember any coping mechanisms for stressors, it's very problematic. We know that HIV can impact the viral replication. It increases both HIV and hepatitis C viral replication. Stimulants are quite interesting. They can have a lot of effects, both in HIV, both in methamphetamine and cocaine use. There's an upregulation of CCR5. We used to be able to tell patients they came into the jail system on cocaine, for example. They'd have lower CD4 counts, high viral loads than other counterparts, which always was quite interesting. And then, as already mentioned, methamphetamines cause neurocognitive impairment, and this might be permanent in people with HIV. This is a 2017 paper. There's been an updated 2020 paper, and basically all papers show that there's no pharmacologic agent that's demonstrated efficacy. And what ends up happening is you'll see a bunch of trials that have really small sample sizes. And in those sample sizes, really small, super controlled, they may see a benefit or signal. When they then try to increase the sample size to validate the finding, those have invariably found no effect. These are some medications that have been studied that have not been shown in larger samples to be effective. Smaller samples that have been. Mirtazapine, for example, was something we discussed on Sunday. This medication has also been found in a smaller sample, again, to be effective. Part of the problem is just when you do these kinds of studies, they tend to control significantly for other comorbidities that we're all facing. So, for example, this study is conducted in people without HIV, people with minimal severe mental illness, and other things that may be a real issue for people that we're taking care of. There's also a mainly male study. So what we really need are larger studies to validate this. And there's currently a study for this medication that's fully enrolled. We're waiting for results. So this LDX is an agonist used for ADHD. And there have been a lot of studies that have tried to look at basically amphetamine or stimulant-based treatment. The reason that was thought to be potentially beneficial is that methamphetamine and other amphetamines have a really long half-life. Cocaine's 30 minutes, so you got to do a lot of coke in a day. But for an individual using methamphetamines, they could use once in the morning, once in the evening, theoretically. Agonist treatments have universally not tended to work really well, likely because they have a really strong reinforcing, they have a quick peak or dopamine effect, which is a liability for abuse, and then people tend to kind of lose control. The hope was that LDX did not give the same kind of positive reinforcement and might be less liable to that. It's currently underway, and hopefully we'll have some data in the not too distant future to help us understand a little bit more about that. So what I'm going to do is I'm going to flip over here to the questions and see if anybody's already started wanting to add in some things in the chat. Again, feel free to unmute yourself and just speak up. If you don't want to do that, feel free to just type something into the chat.
Hello, Dr. Bruce.
Hello.
Hi, I'm Michael Zito Govert. I'm a nurse practitioner at a community health center in Asbury Park. I have a lot of methamphetamine users that are some in various stages of sobriety. And one of the big questions I have, because I often get mixed signals from my, let me start my video. So I get mixed signals from a lot of my patients about how long they've been using. And then I noticed that there's some memory failure, and I noticed there's some delusions and other cognitive changes. And I'm just wondering if there's a time frame of regular use that might actually be those chemical changes within the brain. Like how long would you be using before they would begin experiencing those changes?
Great question. The honest answer is I don't know. Part of it's going to depend on the potency of what you use, the frequency of what you use. We know that HIV itself causes neurocognitive impairment. So if you told me that your patient has a CD4 count of 49, has had the virus for 20 years, has always been poorly controlled, and has been using meth for, you know, even a short period of time, I'd be more concerned about neurocognitive damage in that individual than say somebody who has had the virus for a couple of years, who's never hugely immunologically compromised, CD4 counts 1,000 viral load, they're taking a Biktarvy every day. So I think it's multifactorial. Everything's always more complicated when you add HIV into the picture. And that's certainly true for things that impact the brain neurocognitively. But I think the big things so one of the things that's really important is that people are using drugs despite the consequences. And a fair number of drug users I've met are really smart. I used to have a patient who used to be a history teacher, and I would love to take him to the Yale students, and I would just basically embarrass the students because he would ask them about US history. They didn't know anything about history. I don't know how many, maybe med students learn history, I don't know, but these guys didn't learn any history. And it was a quick lesson for all of them, right? And that lesson was, he's not using drugs because he's stupid. He's using drugs for, in this case, this guy's a veteran. He had been involved in military violence in Vietnam. He'd seen horrible things. This was his coping. It was maladaptive. He had negative consequences. He got HIV and Hep C. He had a rough life, but he wasn't stupid. And so I think that's one of the things that I found really helpful is providing data, saying, look, I get it. Taking this drug is really pleasurable, but let's look at what it's doing. And one of the things that's really, I think, can be an eye-opener to many people is the thought that, wait, I mean, people fear Alzheimer's, I think, in this day and age, more than they fear HIV. Helping people understand that you may not remember your loved one. And like, we should probably do something about that. Now, it's probably a threshold effect, right? So, or a dose dependent effect. So the more you do, the worse it is. And this is a great place for harm reduction and a great place to start talking about it. And I'll do that, for example, with patients in alcohol use. I'll say, look, you're drinking a fifth of vodka every day. Could we move to a 40? Can we move to beer? What can we do? Any reduction in alcohol is going to improve the lifeline that you have to your liver. If you can say, I'm doing meth 5 times a day, could you do it 3? Any reduction is going to have some form of improvement. Great question. Thank you.
Thank you.
So one question being asked is, can any of the negative brain effects be reversed? The answer is, in people without HIV, yes, it takes a long period of time. So they've looked at the data, and it's about 14 months or so, you'll start to see a increase in the number of dopamine receptors, and people start feeling better, right? And some of that's coming back. In people with HIV, because HIV causes its independent neurocognitive effects, the concern is actually that those might be permanent. Again, but that's on a threshold, right? So you have AIDS dementia on one hand, you have hand on another end. And so where is the patient on that spectrum relative to when the methamphetamines came in, how much was used? So I would not promise someone with HIV that things will go back to normal, but I think that's also the reason that we want to emphasize to patients that this is really serious. The way I think about this is kind of like you're already cirrhotic and you're drinking on top of it. I can't get your liver to reverse the cirrhosis, but we could reduce the impact of further damage.
How are you convincing?
Go ahead.
I'm just curious.
Sorry?
I have a couple of young patients who, initially used meth recreationally, and now they're using it regularly, and they obviously don't recognize the problems inherent in that because, I'm assuming as I get older, everyone younger than me just doesn't know as much. But have you had any success in convincing the younger patients of the dangers, especially the long-term dangers of continued meth use?
So one of the biggest problems is the youth, right? So we know that the prefrontal cortex, so the part of your brain that's involved in inhibitory control, doesn't fully develop until your mid to late 20s. And it's one of the reasons that you draft an 18-year-old for military service. If you draft an 18-year-old and you tell that 18-year-old, I want you to go take the hill, the 18-year-old will do it because the 18-year-old's like, I'm invincible. Like, yeah, fine, right? You do that to a 30-year-old and the 30-year-old says, no. I can get shot. That's dumb. You go first, right? So that's a big problem. Young people are inherently greater risk takers. That's why drug dealers prey on young people, right? You want to get somebody who's at the peak of risk taking. So you want to take a rebellious teenager or a teenager who's bored or depressed or in the middle of COVID and all their friends are virtual and say, just do this once. You're going to have a great party. You're going to have the best sex of your life. It's going to be awesome. And if you're an 18-year-old, you're not thinking about consequences. And the other thing is, hey, take this. No one will know you did it. Your parents don't do drug screening. Your friends don't. No one knows what meth smells like on the breath, right? It's not like you drink a fifth of vodka and you come home and people are like, whoa, like I'm going to lock you in your room and you'll never come out. So there are a lot of inherent problems there. The thing that I found most successful is actually having people talk to people like themselves who are farther along in the process. So if I sit down with somebody, they would say to me, Dr. Bruce, what do you know? You're a Yale faculty member, you live in an ivory tower, you don't know what the hell's going on the streets. Of course, I'd be like, I do, like I hang out on the streets all the time, it's a lot of fun. No, but having them sit down with somebody who's farther along the sobriety process and say, man, like I get where your head's at, but I spent 5 years in prison. This sucks. These are the consequences. I can't get a job. That can sometimes carry much more weight than me trying to preach to them. But I'll be honest and say the youth are really, really challenging. And a lot of it really becomes about developing a trusting relationship. Once you have a trusting relationship with somebody, you really then begin to have the ability to speak into someone's life in a more confrontational manner, right? Like your close friends can give you a hard truth that some random stranger can't. And that's what friends do. And so I've known some of my patients for a very long time. And so I'm able to sit down with them and say, look, I wouldn't be a good doctor, a good friend to you if I weren't honestly telling you, if you keep down this road, you're going to destroy yourself. So
I think
long-term friendship and support.
I think that's a great point, Doug. Some people that we've worked with, not so much this year, but 2 years ago, it seemed like that was a common theme. You guys can say this to me, but you don't really know. You're a doctor. Your life has always been blah, blah, blah. And it just, particularly with the meth folks, they really want someone with that lived experience. we often don't have that cred, right?
Exactly right.
But we actually have our CMO and some of our doctors have former use, mostly of other things, and so they can talk on level sometimes with their patients. But meth is so benign in the, there's no meth epidemic, right? People aren't dying greater than anything else with meth. It's just, hey, I do it for fun, and it doesn't have that. I guess it doesn't have that stigma attached that we can say, hey, you're going to ruin your life. I can't get a peer because no one's accepting inpatient meth detox or anything like that.
Mm-hmm.
Right. No, and those are
Well,
huge
there is a
issues.
meth epidemic, but there.
Well, you and I know that, but we don't have cred.
Yeah. So I think one of the things that I also try to help people understand. So my patients used to ask me, "Hey, Dr. Bruce, have you ever tried drugs just to see what it's like?" And I said, no. And the reason I'm not trying the drugs that you're using is because I'm only going to see that the negative consequences of that, the risk potential outweighs everything else. Like there's just no benefit that you could give me from this that would outweigh the risk in my mind. Helping people to start to think like that, like, okay, yeah, I get that it would be great. You know what? It'd be great if I robbed a bank and got away with it and had millions. But what happens if I don't get away with it, right? What happens if somebody robs me? What happens if I get shot, right? So there are all kinds of things where you can try and help people play out. Teenagers don't think about consequences, right? That's why the dog ate my homework. It's not that I didn't do it and I didn't plan ahead. It's just, aliens invaded. I'm going to come up with a creative solution for my problem. So drug users, often like adolescents, don't think about consequences. They don't think about tomorrow. And so they only see the upside, right? Just like taking the hill. I can take the hill, no problem. I'll get a better view. It's not an issue. Yeah, they're shooting at you. You could get shot, right? So helping people understand, well, let's think about the pros and cons of this. You could go out and you could have a great time. What's the negative? There are no negatives. Okay, so you couldn't get arrested, nothing bad can happen, nobody could take advantage of you. So helping people process it can be helpful. But also, again, adolescents are tough. Young people are tough, right?
Thanks.
Absolutely. So love the discussion. I don't want to stop it, but I do want to get to some of the things that people have been putting into the chat. So one of the comments coming in said, some of the most challenging issues with meth users we experience are those who insist they have bugs to explain the skin scratches on their body. So yeah, this is really hard. So stimulants, both cocaine and methamphetamines, will wind up causing psychosis and itching and this bug paranoia where they'll be picking. Heroin can cause itching because opioids cause a histamine release. So for the opioid users, you actually just give them an antihistamine. For the stimulant users, they also don't respond to logic. They get more and more paranoid. So this is really difficult. So in this situation, it's often actually trying to address the psychosis. I had a guy who we gave him permethrin, we gave him treatments, right? But he had just was smoking crack, but he was convinced, right, that it was invisible, that we couldn't see it. Then it was, if it can't be a bed bug or whatever, maybe it's a flea, it's microscopic. It was just, we actually had to get him hospitalized and on meds in order to stop the cycle. If you can get the person off the drug, the cycle stops. The other part of that is just the harm reduction. People scratching and picking, things will get infected. MERS is a community-acquired infection, so you have to be careful that people don't wind up with cellulitis and other consequences. Another person is asking, is the frequency and amount of meth use congruent with the speed of brain changes, all other factors being equal? That has not been formally studied, but yes, that is the presumption that it's a dose-dependent toxin. Another person is asking about naltrexone that wasn't on the list of medications. My apologies for that. Naltrexone's best use is in alcohol use disorder. It is the best medication for that. Every study that's been done shows it's the best. It is not effective in the long term for methamphetamine use. Now, I will tell you that the placebo effect is incredibly powerful in all things. So all things being equal, somebody who believed naltrexone would work, but pharmacologically, we have not found it to be that beneficial. What would you suggest for an ART regimen that helps reduce resistance development for those who are very unreliable in taking medications or are in and out of jail systems? So great question. So the first and foremost thing in any HIV adherence program is talking to the patient about his or her life cycle and what they do in a given day. Where are the neighborhoods you go to? Where do you do? What do you do? How do you do it? And that's really important because what you don't want to do is say, here's a bottle of pills, figure it out. You want to help the person figure it out. Remember, they may or may not be completely sober and talking to you. They may or may not be, depending on their stages of change, really on board with sobriety or taking the pills. So you've got to really get into the weeds there. A couple examples. Number one, I was taking care of a guy in prison. I used to do prison HIV care. And he gets locked up. He comes to see me. Oh, I've had the virus since the 90s. It's no big deal. I've totally, made my peace with it. I just need help taking my pills. Okay, I'll get you your pills. Take them. So he doesn't take them. What's going on? Oh, I don't want them in the dorms to know that I have it. Okay, fine. We'll put it online. Just make up an excuse. Come and tell people you need your blood sugar checked every day. We'll give you your pills and the medicine. He never comes in to take his pill. So I sit down with him and I say, I don't understand. We gave you the meds. You didn't want to have them in your dorm. Totally got that. So we brought him over here, but you never came to get him. I'm starting to think you just don't want to take these pills. That's when he said, really, every time I look at the pills in my hand, I remember I have HIV, and I just don't want to deal with that. So for him, his adherence issue wasn't drugs, it wasn't incarceration. It was the fact that HIV was so stigmatizing that he had actually not even had a real time to cope with the diagnosis. And part of that was he'd spent a whole lot of his time post-diagnosis intoxicated and high. He'd never had time to actually kind of come to terms with what the diagnosis meant for him personally. So that's really important. Don't assume that just because people have had the virus for a long period of time, that they've actually been sober long enough to actually come to terms with it. The other big issue is not just structural like that or historical, but it's that people, our patients oftentimes are still struggling with the same kind of adolescent coping mechanisms that we talked about a minute ago. And so they're not thinking about tomorrow. They're not thinking about what kind of daily regimen should I associate with my HIV therapy. They're thinking about where do I get my next high? Where am I sleeping tonight? Is it safe? And so it becomes very helpful to walk the patient through and say, okay, well, what do you do every day? You get up every morning, you go to bed. What's your pattern? And then to work with that person to fit into their pattern. And we're all taught this. So you brush your teeth every night, put your pill bottle next to your toothbrush. It will remind you every night to take your pill. Well, that works if you've got a place to have a toothbrush and put it there. But if you're homeless or you're in and out of prison, that doesn't work. So make sure that you spend some time trying to parse out what to do with the patient. The other things that we recommend are thinking about other forms of adherence support, whether that is having your HIV case managers involved in support, whether it's helping to get people into the habit. Remember, so if you're a substance user, get them into an inpatient program, maybe give them some structure, help them get into the rhythm of taking their medication. You're trying to introduce a new habit into someone's life. And that person may or may not be as motivated to take the medication as you are. So those are a couple really simple things to try and help address in the person who's actively using. Patients will take their medicine when the services and the treatment are organized around their needs. So we have done HIV adherence therapy through a mobile unit and a methadone clinic. You name it. Send people out on the streets. You really have to sometimes be very creative in finding ways to solve that problem. So here's a question about some of the slides. Besides harm reduction, CBT, which is cognitive behavioral therapy, motivational interviewing, is there anything else we can do? I found, and this was not something that I realized how important it was. So let me digress a minute. When I was doing drug treatment work in East Africa, I was really amazed at, as people became sober, the first and most important thing for their lives was to re-engage with family. I mean, that was like the most important thing. Was if you would tell them like, why are you smiling? Why are you feeling great? All right, is it because you're sober? No. It's because I'm back with my wife. I'm back with my kids. I'm back with my partner. Family is really important. A community of people who support you and care for you is super important. We're social beings. And so one of the things that was really interesting is, so the patients that we've taken care of are marginalized, homeless, lots of severe mental illness. They don't have community. The community they have is people who use drugs. And when you're asking someone to stop doing drugs, you're asking them to leave that community. And we shouldn't underestimate how painful that is. There's like a grieving process. You're giving away your friends, all the people you know, the people that may or may not actually care about you, but maybe a little bit, but they're the people you know, and you're trying to go to another community. So that's kind of the long prelude to what else can you do besides harm reduction, CBT, and motivational interviewing. It's be a consistent presence and an honest presence in the life of patients. So one of the things my patients, I think, appreciated was I wasn't going to lie to them. So when I could say yes, I'd say yes. When I'd say no, I'd say no. And it was just like, look, you shouldn't do this, or you can do this. I have to take your methadone bottle away. You're smoking crack. Sorry, it's the way it is. People get frustrated, but my patients always knew that I was there for them. And why is that important? Because you never know the day that somebody's actually going to show up and it clicks with them. They're ready. I'm done running the street. I'm done being homeless. I'm done living this life, but I don't know how to get help. Who do I turn to? I turn to a trusted person. If you as the provider are that trusted person, they will come to you and they will ask, I need a way out, help me. And I think that would be the other thing that I would add. So would we theoretically be legally able to use amphetamines for a form of medication-assisted treatment for cocaine meth use disorders? Would this fall under the Harrison Act that prevents us from using morphine to use heroin disorder? Yes, so if you, the Harrison Narcotic Act was particularly focused on heroin because heroin was coming back from Germany after World War I. And heroin is the brand name for diacetylmorphine. It was made by Bayer Pharmaceutical Company. It was something they put in everything from cough syrup to you name it. And so that's what led to the Harrison Narcotic. They weren't thinking about amphetamines. So legally, I don't know whether or not a court would want to broaden it. I will tell you the DEA would not be overly happy with anyone giving a stimulant to a stimulant abuser. They would probably look at that under the guise of fueling their habit, and or they'd be concerned that you're basically a drug dealer. If you're not profiting from it, then maybe you could get away with it. The bigger issue is that amphetamines have not been found to really be the most effective treatment for methamphetamine abuse. So I would stay away from that, honestly. Can you talk about the harm reduction continuum for people who use meth? Of course, reducing amounts, but what about different methods for using? Absolutely. So one of the things that people may gravitate to is injecting. And so that's one of the things that we want to really help people, prevent people from doing. So, if, I never thought I'd say that crack cocaine was a good thing, but some stimulants like crack, which is very potent, is so potent that smoking it is the same speed onset of action as injecting it, right? So one of the things that I would want to talk to patients about is, what is it, why are you injecting? So oftentimes people start injecting drugs because they are introduced to it by someone else. So I would view part of this as soon as your patient starts talking to you, you find out that the person uses methamphetamines and that person does not inject, you want to have a conversation with them about it. And people will say, well, I probably shouldn't do that because maybe I'll prompt them to inject. That's the same logic as I'm not going to teach somebody about a condom because they might use it, right? What you want to be able to do in the injection conversation is say, look, if there comes a time in which you're thinking about ever injecting this stuff, we need to have a serious conversation. There are huge risks to you injecting. Endocarditis, Hep C if you don't already have it. Like it's really bad. It's really bad. And if you cross into that threshold or thinking about it, you could really put in your life in jeopardy. So framing it in a way like that, trying to get ahead of it's really important. The other things are really around trying to, and part of harm reduction is meeting people where they are. So it becomes an important assessment, both to set up for today's conversation and the future conversation. So today I'm going to say, okay, hey, what's going on? Oh, you're using meth. How much are you using? All right, okay, well, I'm using, I'm doing it 5 times a day. Okay, well, how happy are you that you're doing it 5 times a day? you know, are you really happy about this? You're not happy? So you can start playing around with it. That's motivational interviewing. So that's starting to talk about, well, what are the other ways for this person to think about it? You could ask, well, why are you using it 5 times a day? Why not 4? Why not 6? Like what's limiting at 5? It may be, oh, that's all I can afford. It could be, after 5, I feel really bad. I get really paranoid. It could be any number of things. But then if you can start to move into the, well, you know, we've been talking about your concerns about methamphetamines. We've been talking about how it impacts the brain. We know that if you're doing it 5 times a day, that's causing more damage to your brain than 4 times a day. How important it is for you to, you know, go from 5 to 4? Is it like on a scale of 1 to 10? Is it like super important 10? Like this is something you want to do right now? Or is it like a 1, kind of like me, you know, not really that interested. Talk to me next time I see you. So you get an answer to that. Then your goal then simply is a conversation of, okay, well, you tell me that it's, say you tell me it's a 7, right? And that could be a social desirability bias. They feel like you got to say something positive to your healthcare provider. Okay, so you're telling me it's a 7. That's great. So you're interested in potentially reducing it. How confident are you that you could actually do it? I hear you want to do it, but wanting to do something and doing it are different. How would you actually do it? Like, is that on that same scale of 1 to 10? Like 10, like, hey, it's no problem. I could just stop it tomorrow. I got a great social support. Or it's a 1, like, there's really no way. Like, you know, okay, I want to do it, but really practically I'm not going to do it. That's important because you're now teasing out where you need to work in the harm reduction framework with the person, right? The person that's not motivated at all to stop, you're working in the pre-contemplation idea. Okay, this guy's not understanding or really internalizing the negative consequences. We'll talk a little bit more about the brain stuff. We'll talk a little bit more about how this is increasing your HIV viral load, it's decreasing your CD4 count. We'll talk about other consequences, right? So that can be very helpful. If the person's motivated, like, no, I really don't want to reduce it. I just don't know how. That's a different kind of intervention. Okay, well, how can I support you in this? What are the things like we could do? Is coming in twice a week? Is getting connected to a therapist? Is, you know, what can we do to support you? And by engaging the person and helping them think about it, that's really important for a recovery. The person needs to be able to actually have a sense of ownership. This is my problem, and I can actually, in working with my healthcare provider, work to try and figure something out. So that's some of the stuff that would be really important to think about. Another question, I have a few patients that have severe ADHD at baseline who are also meth users. Are there good ways to manage both? In our world, what we do is we will, so when somebody who has a co-occurring disorder, we'll get them connected to a mental health provider. And so we start trying to help the patient disassociate things, right? So, and you can do that some structurally by having different people involved in care. So what we don't want is the methamphetamine user to say, I have to do meth because I have ADHD. So that becomes a problem, right? That's like the heroin user saying, I have to do heroin because I have back pain. And so what we try to help patients understand is, okay, yeah, heroin treats pain. Meth may help your ADHD, but taking those drugs is not the normal course of action for ADHD or for chronic pain. There's something else going on here. And then for the meth user, it's how, you know, especially for the person who's been using a long time, they have HIV, they have neurocognitive impairment. How do you even know that you are actually have ADHD? I mean, those are like the benzodiazepine patients that we have that come into us. They're out on benzos, they're eating lots of Xanax, and they'll say, I am, you know, I have a panic disorder, I have generalized anxiety disorder. That's why I get shaky if I don't take my Xanax. And we would say, no, you have benzodiazepine use disorder. You are physically dependent on this drug. If you stop it, you're having benzodiazepine withdrawal. Withdrawal is what's causing you to feel absolutely miserable, not that you have an underlying panic disorder. The patient may, but sometimes you have to get them off the benzos in order to figure that out. So someone was clarifying that, oh, sorry, I've got like so many happening all at once. So I have a patient with multiple arm muscles from skin popping and injecting. Person's prescribing a topical antibiotic that has activity against MRSA. So absolutely. One of the things that I tend to want to ask people that are doing, especially skin popping, is try and tease out why they're doing it. Are you doing it because you don't have venous access? Are you doing it because of some other reason? Kind of when you look at the skin popping behavior, it seems a little bit like cutting. And so, because you're inflicting pain, causing damage, just like the cutting. And so part of that becomes a question of, are there other underlying psychiatric things that are going on? And that becomes really important to try and get to the root cause. A lot of addiction is really trying to get to the root cause of what's going on. Because if you think about drug use as a coping mechanism, and I'm taking away your coping mechanism because of something else in your life, you got to fill it with something else. So you'll see that like on a methadone program, right? You'll see the patient who, yeah, you know, I didn't really do a lot of alcohol or coke, but I got on methadone and suddenly I'm doing these other drugs. I'm having cravings as a result of methadone. Well, that's not true. What's happening is I took away your heroin coping mechanism, say for your past trauma, and you don't have a way to cope with that past trauma. So your only way to cope would be to use a substance. If you use heroin, it's blunted by methadone. So I'm going to find something else to make me feel better. So that's one of the big reasons that we try and tease things out with patients, is because it helps you start thinking about, well, what do I need to do? Another example, I was talking to a young woman who we were putting on her buprenorphine. And so the question arose around, well, you know, how old were you started? I was 17, okay. I don't, trauma is a sticky thing, so I don't like to get into the details of trauma. But she basically said, look, you know, something really bad happened to me when I was 17, and then I wound up doing heroin. You find out later she was sexually assaulted. That led her to use heroin. Heroin was her way to cope. And one of the big things that came out was that she got connected with a counselor, and that counselor wasn't very skilled in trauma therapy. And one of the big things is, you never open up something you can't put back together. And that happened with this client. And she wound up overdosing. She survived, but she OD'd on a benzo because she couldn't handle, and this is not demeaning to her. I mean, like, it's horrific, right? It's the counselor's fault. You don't open something you can't fix. So what happens is she wound up suffering under this trauma, the anxiety of reliving it. She went and did a bunch of benzos because she couldn't do heroin. And so we actually had to put her on methadone. Methadone has more of a sedating effect on some people than buprenorphine. And so that was a way to try and provide her some additional coverage and anxiolytic support, in addition to other psychotropic medications, to support her through a time until she could face and address her trauma. So super important, great questions. LDX for meth use disorder is another question. Is that in similar vein as methamphetamines? Yes, so it's the same idea. LDX is a stimulant, so it's under study right now. There's a clinical trial in the US, and the goal is exactly that. Try to get the person something that will last long enough, function as an agonist. As mentioned earlier, it's an issue that unfortunately we have not found agonists to be as helpful in methamphetamine use disorders as we have found with opioids and opioid use disorder. So back to the gentleman who's doing skin popping. So Elizabeth just mentioned that his really big ulcers, the patient statement is that he can't hit his own veins anymore. But she hadn't been sure if it was destructive or if he's skin popping, like what he's doing. So remember that when if you're a dealer and you either make methamphetamines or you purchase them, you always want to step on the medication, right? So meaning when step on is you adulterate it, you add stuff to it, because that's how you increase your profits. If I can, buy something and increase my sales by tenfold, like that's an amazing business model, right? So that's a really big issue, is people put junk into the drugs that are used. So it may or may not even be methamphetamine this person's using. There may be some meth. There have been issues where people put meat tenderizer in drugs. I mean, because the drug dealer is looking for something cheap that mixes and matches color. You also have to realize that drug dealers benefit from adverse consequences to patients. So this happens a lot with opioids. When there's a rash of overdose, it actually increases sales of the person selling it because people think it's better drug. So that may be one of the other issues, is that if people are like, oh my goodness, like the meth this guy is using, look what it does to him, it must be really good stuff, that actually increases sales. And it's kind of twisted, right? I think a lot of us would be like, oh my goodness, that's terrifying. That's scary stuff. Some people actually run to that. Drew's reminded us to unmute and contribute. Absolutely. I'm just reading these off until someone chimes in. So feel free to interrupt me at any time. Someone's asking, if someone generally suffers from a substance-induced psychosis, how soon after stopping the meth would you expect someone to return to normal? Unfortunately, psychosis sometimes doesn't go away. Active psychosis may get better with treatment, but people may actually need medications indefinitely. That's more common in cannabinoids. Cannabinoids do something to the brain that you can't always fix. Methamphetamines, it's a little bit more complicated. Assuming the person has HIV, the person may or may not return to normal. So I had a patient with an issue with wounds. I asked if his meth is different colors. Could be the base. Yeah, I mean, people mix all kinds of things. And I had a patient of mine who we were giving directly observed treatment for HIV. He was also getting Bactrim for PCP or PJP. Back then it was PCP. And he would crush the Bactrim up into a white powder and he would sell it as a bag of heroin. And that didn't last very long. But I guess he got some people's money for a while. I have no idea what injecting or snorting Bactrim feels like. How effective have you found group work to be? We have an acceptance commitment therapy group that was prematurely shut down due to COVID, but several folks expressed disappointment that was no longer available and have expressed NAA weren't targeted enough for their needs with regard to methamphetamine use. So one of the things, again, back to the earlier comment, it's super important for people to have access to a supportive, sober environment. And so that doesn't even have to be about drug use. So I tend to encourage people to do more, not less. So, and COVID's messed up so many things, in the world. If you could actually get people on a Zoom call or whatever, that can be very problematic. Our homeless team, I bought these Kindle Fires for $50 that have a video component, and I sent them out with the homeless department so they could actually do a video into the health center, into the psychiatry department, so that if they ran into somebody, they could actually do a video chat. And so whether it's taking things, and we bought the Kindle Fires because they're so cheap, if patients stole them or walked off with them, I wasn't really going to worry about the $50. So, but the point being, you could either bring things into the field. We've actually started bringing a substance use counselor onto the streets to try and help engage patients. So a lot of times it's really trying to slowly work with a person. If you can do a group on Zoom or bringing things to people, that's great. If you can't, encouraging people NA and A, that's also great. If people will do it all, that's great. Faith communities can also be great sober environments for people. So, I've even told patients, you can come to the clinic every day. That's fine. Like, we'll be nice to you. I will not bill Medicaid every day that you come to the clinic, but you can come hang out in the lobby, read a magazine, do something else. When in Tanzania, the methadone clinic actually started to employ the patients to do landscaping throughout the hospital complex. And part of that was really just trying to give people sober work and a sober community to be in.
I think that's a great point, Doug. There's a person in our town who he's pretty strict, but he's a person that's living in recovery from alcoholism, and he has several restaurants in town, and now he has like this breakfast lunch place, and He hires people that are in recovery. And so number one, they're employed, they're working, they're busy, but then they also do trainings where they teach people, just like going back and learning, or maybe they never learn, but just like basic things of life, right?
Right. Yeah, no, and then you got to think about it, a lot of people who have started in the either doing drugs, selling drugs or whatever, do so at a young age, drop out of school. So, we've got patients who are illiterate who, signed their name with an X. It's really tragic. And so you get sober, you try to get employment, you try to become a productive member of society, and society is not forgiving. Your probation officer, his or her goal is not to be your best friend. And so it's really a challenge. Alice, it's so great to hear that there's a community like that wanting to actually support people who are coming out. I think it's super important.
Yeah.
If there aren't things like that, institutions. We had a whole program at Yale years ago led by Emily Wang and others it was a ban the box campaign. So the box for many people, it's oftentimes in an employment package. You have to check off whether or not you've been incarcerated. And so often that becomes a barrier to employment. And Yale University, Neil Navin Hospital had a box, and they worked really hard to ban the box. And that was really because if you come out of jail and you have no possibility of employment, you cannot get a job. What are you going to do?
Right.
Well,
Right.
you're going to go back to
Exactly.
selling drugs. That's the only thing you've got.
Yeah.
Katie's asking, are there any meth-specific community-based interventions for which we can advocate? A safe station, mobile crisis, etc. Absolutely. So drop-in centers can be a great thing as a place for engagement. Depending on your municipality, the U.S. government's not too excited about people doing drugs on anybody's property because of the concern that you're aiding and abetting. I actually had that conversation with the U.S. Attorney's Office because we were trying to think about what kind of creative things could we do in our jurisdiction. That was one thing that we were not able to do. But having a drop-in center where people aren't doing drugs but are coming in safe. Our detox center, for example, has showers. It's got laundry facilities. People could just come in, wash their clothes or whatever. That can be again, that goes in the whole kind of trust safe space. Drug users are not naturally trusting, and that tends to be because that's a survival mechanism. So building trust is really important. Mobile crisis can be really helpful. Our homeless, so we have a street medicine team based a lot off of the work of Jim O'Connell and Jim Withers. O'Connell's at Boston Healthcare for the Homeless, and where we actually go out onto the streets and provide care for people. And so that is oftentimes kind of the most marginalized individuals, the people who are not organized enough to get into care. And so that's a kind of a form of mobile crisis. And they work closely with the police department, EMS, and the hospital system. So what I would say is be creative. One of the most important things is to sit down with patients and to ask them what they think they want. There's a big campaign that started many years ago for substance users, and that is nothing for us without us. And the basic premise of that is, again, back to the earlier thing, drug users aren't stupid. They're caught in this horrible cycle of drug use, and they need a way out. And so one of the important things is asking people, what do you want, right? And they may say, hey, don't come over to this neighborhood. You come over to this neighborhood, you're going to bring the cops. If you bring the cops, then we're going to get locked up. Or they may say, hey, you don't know about this area, but this is a place where it'd be really helpful. Our street medicine team, by just being a consistent face on the streets, has developed trust. And so then people start telling each other, oh, well, hey, we're really worried about so-and-so. He's over here, he's sick. And we've been able to get people connected into care, both from the streets, from other, from shelters and other things. So I would say be creative. Other questions that folks
I think
have?
your point about having people involved, something that we encountered in our hospital, and our hospital is, at least in some form or fashion, been trying to work with our people who inject drugs for about 8 years now. And the lawyers and the administrators came up with a contract for inpatient behavioral contract. And I asked the question, of course, because HRSA expects this of us, which is unusual for the hospital, but I asked the question, how many patients read your contract and gave feedback? And the room was very silent. And I was like, did any patient? And they were like, well, we didn't really think about asking any of them. And I'm like, well, don't you think, I mean, you need their input.
Yeah.
And it was just a completely foreign concept, which, you know, HRSA being Ryan White, I've been in Ryan White for 20 years. That's, you know, very much so, but not in the community at large, not in the health community.
That's a great point. I think we shouldn't take for granted the fact that large institutions, people drafting contracts are the lawyers and public policy people within the institutions. And they're just, you know, the purveying idea is that drug users are difficult and stupid and bad people. And when you have that kind of an idea, you don't invite those individuals to the table. But if you were to flip it around and say, well, you have a contract for cancer treatment, did you have anybody who's ever had cancer talk to you about whether or not this contract made sense? I think they'd feel very ashamed, particularly if they hadn't done that. But most likely they would have. They would have said, oh, well, you have to have, you know, breast cancer survivors comment on this. You can't just unilaterally do this. But people feel a great latitude to do that with substance users. Just as we wrap up, you know, one of the things we've talked about a lot today is the critical importance of trust. And Alice, as you were mentioning that, I just was reminded of a story of one of my long-term patients who had been through the foster care system when he was a kid and had multiple different moms. The final mom that he wound up with was a cocaine dealer. It's unclear how that happened, but so not surprisingly, he has also bipolar disorder. He was a transgender individual. In the time that I knew him, he moved from being a man to a woman, and was struggling greatly with cocaine use, serious mental illness, you name it. He had HIV. And I remember getting the call when he had been hospitalized. He had overdosed. Actually, he had overdosed in the hospital, which is a whole separate problem. And he was on a ventilator, and they were trying to determine what he wanted to be done, and they couldn't ask him. He had no family to ask. And so I got the call as somebody that knew him to say, could you come to the hospital? And could you help us understand what she would like like us to do? And it was a heartbreaking call. One, it was heartbreaking that this had happened. It was also heartbreaking that after so many years, there was nobody to be at the bedside to help with this decision. And so it was just tragic. And the reason I say this is trust. You may find that even though the patient is very difficult, very disagreeable, any number of things, that the patient really cares about you and cares about the relation that's developed, because you might be the only caring person in that individual's life. Don't underestimate that, and don't underestimate the power of that for good, positive change. If you want a book to read that has nothing to do with medicine, but everything to do with medicine, read Richard Thaler's book, Nudge. Richard Thaler won the Nobel Prize in Economics, and he wrote a book with Cass Sunstein, who's an attorney. And that book is about decisions and how to nudge people to change behavior. So I read this. I'm a nerd. I have problems, right? So I read lots of books. So this book, though, I read this and I thought, why isn't everyone in healthcare reading this book? Because this is about behavior change. And I say that because if you have a trusting relationship with somebody and you have the opportunity to speak into their lives, you can help nudge them to good things. And that may not be eternal sobriety, but that may be reducing drug use. It may be accepting Hep C treatment. It may be taking HIV therapy. And all of those are good things. And make sure that you celebrate all the victories. You know, that drug users come in so burdened with guilt. For them to come in and say, oh, you know, the number of patients I've had who've said, I relapsed. I've lost those 10 years of sobriety. For me to be able to say, no, you haven't. You didn't lose 10 years. Those 10 good years still exist. Don't give up. You had a bad day. We all have a bad day. Everyone screws up all the time. Don't throw in the towel. People need to hear those messages. And everyone stopped moving.
That's really important.
Some people are still moving. I don't know if people can still hear me.
Can you hear us, Doug?
Oh, I can hear you now. Yay.
Okay. I was just saying, I think that's so true. And something that I've learned from taking care of some of the folks in the hospital is exactly what you said. So often we are the only people that kind of give a shit. I mean, honestly, maybe they were born into a family that didn't care. Maybe they've, severed their ties or whatever. And just a little bit of kindness that we would show anyone, I think it just goes such a long way.
Absolutely. Absolutely. And the patients remember it. They really do. It became kind of this strange thing where, because patients aren't often used to long-term relationships with providers, I would have people tell me, oh yeah, you gotta see Dr. Bruce. He's been my doctor for like 25 years. And I'd be like, yeah. Of course I'm nodding. I want to be supportive, but I'm thinking, I haven't been a doctor that long. I lived in Texas when you're talking about that. But for them, it was just their way to say, I've known this guy a long time. He's good people. I'll take care of you. So Judy's reminding all of us, so those who can read it in the chat, otherwise I'll read it out, that we have a few minutes left. The opening session of the National Ryan White Conference on HIV Care and Treatment will be provided through the clinical conference site. You can return to the clinical conference site to view the session. However, if you have registered for the national conference, please use your assigned login to access the live stream, and that will begin at 1:30 Eastern time. I want to thank everyone again. One of my mentors always, Jerry Friedland, would always remark that taking care of people who use drugs and have HIV, there aren't a lot of people lining up to do that. But you should always remind the people that do that what special people they are. So thank you so much for caring enough about patients, caring enough about the dignity of individuals, that you're willing to look past the kind of difficult and trying things that people may say to you or do to you, because you see beyond that to a human being who needs help, and you have the means to help that individual. So thank you all so much. Hope you enjoy the rest of the conference. And I look so forward to talking to everybody tomorrow in the plenary on opioids. Hope that you can join us, because we'll be talking about sex, drugs, and rock and roll. Thank you all.